Okay, it looks like I'm recording. Hi, we're going to start with recording the neural assessment. Hello, everybody. All right. Hi, my name's Austin. I'm going to be your nurse. What brings you in today?
Just a regular checkup.
Just a regular checkup. Great. Okay. I've used some hand sanitizer, as you just saw. I'm going to be closing my window for privacy. We would start with he was able to tell me that he is coming in for a visit, which would tell me he's alert. Do you know what day it is today?
Yes, today is the 1st of July.
Today is the 1st of July, so I know that he is alert. He is also oriented to at least time, right? If I wanted to just for sake of documentation, I could note both level of consciousness, and I can note a degree of orientation for him. His speech is clear. There is no slurring. The rate of speed is good paced. I don't like that word. Now I'm using the word I told y'all not to use. is paced. It's not fast. It's not any kind of issues with ideas not connecting. It's good congruence and fluency. I'll use the words that they've given to us, right? We're gonna start with testing sensation. So I'm gonna start with testing your sensation here in 4 extremities, okay? So I'll start with bringing it down so you can see here. Can you feel this here?
Yes.
Okay, you wanna close your eyes for me?
Yeah.
And do you feel here?
Yes.
And do they feel the same?
Yes.
And what about here?
Yep.
And over here?
Yes.
Okay, if I was doing this for real, folks, I would wanna have maybe like, what I like is like a little broken Q-tip if I would have it. And I would also be able to ascertain if he could ascertain the difference between sensations of sharp and dull. While I'm down here, if you can please open your eyes and put your arms up for me like this. I'm gonna push against you. If you could just resist my pushing against you, okay, good. Now I'm gonna pull. If you could resist my pulling against you, the other way, good. If you could hold your hands here and squeeze my fingers on both sides, good. Strength. So strength is bilaterally strong in both arms. The grip strength is also equal on both sides. It's strong on both the left and the right as well. For strength of the legs, it's the same kind of thing. I'm gonna do resistance of the legs. I don't suggest doing these together only because oftentimes if you have a patient put both legs up like this and push back, that you're gonna shove them back, so I don't do that. I do the legs one at a time just so they can be grounded. So we'll start with this one leg. If I'm gonna push against it, if you just wanna resist me down here, good. And on the other side, so comparison, good. And I'm gonna pull if you wanna resist me as well here, good, good. And on the other side, and good. Okay, so strength in both legs is strong and equal on both sides, the left and the right. And it is definitely strong on both sides, so strength is good. Okay, if I can have you, while I have you standing, I'm gonna go ahead and just have you open up your hand for me and close your eyes again, I'm sorry. And I'm gonna draw something in your hand, and if you could tell me, it's gonna be a number. Tell me what that number is when I draw it in your hand, okay?
Okay.
Okay.
8.
That was the 8. Okay, now keep your eyes closed and I'm gonna put something in your hand. And if you can tell me what this item is that I'm gonna place in your hand, that would be great.
It's a pen.
It's a pen, good. Okay, so he was able to accurately identify both the graphesthesia as the letter 8. He was also able to accurately identify the stereogenosis by identifying accurately the item of the pen that was placed in his left hand. Okay, now I will go ahead and have you stand up for me, if you will, while we're here. And if I could just have you while you're standing, if you would close your eyes for me and just stand in one place, we're gonna just test you for balance and see how you do, just for a few seconds. Great, okay, so Romberg test, there's no swaying, right? Okay, and you now will just take a couple of paces here, we're just walking back and forth so we can check your gait, get a sense of his gait. So gait typically is even, steady. Okay, great, you can have a seat. There's no difficulty, there's no ataxia. Typically with gait, we talk about people often having at least a foot or two distance between each step. There was no difficulty with his gait at all that was noted. Okay, and then the last part of this exam, we're gonna be doing some of these deep tendon reflexes I'm gonna walk through. And we're gonna, if I had my little brachial hammer, I would kind of play with these. So we're gonna just kind of simulate some of these. The first one I'm gonna do, we're not gonna play so much with the brachial one, but if I had the brachial one, I would go ahead and kind of tap them here and kind of see if I get any kind of a reflex here. You can see that, you kind of hit it here. And then again, I would do a comparison, always comparing. I want to be comparing left and right. And the same thing here with brachial, what's it called? Brachial radialis. It's kind of the same thing. You want to be tapping the arm up a little higher on both sides. If I had my reflex hammer, and I'd be seeing if what kind of reflex I would be getting on the patient. Higher up, you'll be hitting it on the bicep area. And again, these pictures are noted beautifully in your book here on page 704. And they're tapping him for the, actually they do a bicep and a tricep one. They're doing some that we're not doing. But the bicep ones, they're actually tapping him here inside the crease of the arm here. Right, so for bicep one, you would be able to hit them there and see if there's a reflex on top of your thumb. And let's see, then we would go to the patellar one, which is down on the quadricep area. And it would be down here in this area on the knee, and you would hit here and see if you got any kind of a reflex on the left and the right. The Achilles one is down further on the ankle. Let me see if I can angle. Oh yeah, we are angled down. And you would be tapping him. Let me see where this one is. I'm not as slow with this one. You'd be tapping him, taking him by the foot, and then tapping him on the back side of the ankle this way, and getting a response on both the left side and the right side to see if there's any kind of reflex there. And then the Babinski, which is an interesting one. I'm gonna put your foot up this way. Babinski is going from up to over to down. I don't know if you can see this in the camera. This is Babinski reflex. I had an item. Let me see, try this pen. Okay, it's basically doing this thing. Yeah, okay. He's doing it. He's kind of going the other way around. Are you ticklish?
A little bit.
That was going, yeah. But it's the idea that I go up and I would see this toe out fan out the other way, but I'm going from the base of the foot, from the bottom, up and over that way, okay, to do a Babinski. Okay, and I'd be doing that on both feet on the left and coming up and over and on the right side. He's really ticklish on both sides. Okay, and that would be a Babinski in terms of looking for Babinski reflexes. And that would be enough for me to satisfy me that you have run through the motion on that part of the exam. So I'm gonna put a pause there. Let's take a quick. Okay, hi, so this will begin our musculoskeletal exam. Okay, hi, I'm Austin, I'm gonna be a nurse. We're gonna start a musculoskeletal exam. What brings you in today?
Just a regular checkup.
Just a regular checkup. I've used my hand sanitizer. I provided my patient with privacy. Okay, and so I'm gonna start with just inspection of him before I have him do anything. So if I could just ask you to stand up, would be the best way for me to do this, so I can just inspect your whole musculoskeletal system. So I'm gonna be looking from him from head to toe, looking at the whole structure for any kind of bony deformities. I don't see any bony deformities. I'm looking down the midline. He looks symmetrical on both the left and the right in terms of both extremities, both legs, both arms are equal. There's no deformities noted on either upper extremities, no deformities noted on lower extremities of the musculoskeletal system that are noted on observations. There's no discolorations, there's no swelling, there's no muscle mass deformities that are noted. If I could have you turn for me sideways, please. So I want to now take a note of the spine curvature and posture. His posture, he has an upright posture. I don't see, can you see this on screen? Let me go up a little bit higher there for you. Upright posture. I don't see any lordosis, kyphosis, or scoliosis noted, but this is the end, just inspection, just looking at what I'm looking at so far. I'm going to be seeing if I note any deviations in curvature. I'm also noting as I'm going to start putting a light hand on. I'm not going to palpate. This is where I'm going to use my 2 fingers I told you about. And I like to run my 2 fingers here from up from the skull, and I just run them down the spine. There's a nice curvature of the cervical. Here's my nice thoracic curvature. And then I come down further. There's my nice curvature here in the lumbar sacral area. And he has a nice curvature in all 3 areas, both the cervical, the thoracic, and the lumbar sacral area. And again, the spine is at midline. There, again, is no deviations in terms of spinous processes or deformity or deviation noted. I did not note any slippage or forward fold in his spinal column as I was palpating that. If you could turn toward me, please. We're going to check your jaw for TMJ. If you can open and close your mouth. Okay. There is no clicking of TMJ, so I don't feel anything that's going on there. There's no temporal mandible joint clicking. Is there any discomfort or anything when you have that? No. Great. Okay. So next I'm going to move to my 3rd section, and I'm going to start with assessing my range of motion. So we're going to start. If I could just have you move your neck forward and back. Good. Side to side, ear to ear. Oh, that was a good crack. Yeah. I can have you go all the way around to the left, all the way around to the right. So good. Full range of motion, not good. Strike me for good. Full range of motion in the neck in all directions, left to right, side to side, and around. I'll come up with better documentation, but this is pretty good on the fly. If I could now move to your shoulders, if I can have you, for your shoulders, can you see me? I need to put us both, step back a little bit, For your shoulders, if you can stick your arms out for me, please. And just give me full big windmill circles. So full range of motion that way forward. Can you go back? The other way, full range of motion back the other way. Great, let's see, what else does that shoulder do? That shoulder goes, if you can go across your chest with your one arm, great. You come back and do that with the other arm as well, left and right. Abduction of the arm. If you can bring the shoulder back behind the arm, one way, good. Good, he's able to do all motions. Good, let's see, what else am I missing? We did up this way, forward, front, and back, good. Up this way, good. And what about back? Let's see if you can go back. And the shoulder does this as well. So he has full range of motion of all movements of the shoulder, ball, and socket joint. I'd summarize it sort of that way. Elbows, if you can give me elbows, it's a joint, it's a ball and socket joint. If you can just show me if you have full range of motion here in both the left and the right elbow joints. Terrific. And we'll go down now to your fingers. If you can just close and open your fingers. And can you Open and close them this way for me. Great. For your wrist, if you can just make a tight fist, and can you fold your wrist forward and back, and make circles with them, and then side to side. So he has full range of motion in both fingers left and right, both wrists and both joints left and right of all the phalanges on both hands left and right. There were no limitations noted on either of the hands. So that covers that. And then now for the hips, if I can have you bend forward and touch your toes. Good. You can come up. And this is able to touch his toes all the way. Can you bring your foot up? And the other leg up. So the knee's good. And if you can kind of bring your knee up and kick out, up and out. See what that knee can do. Good. Up and out on the other side. Oh, excuse me. So the knee has good range of motion that way. And for you, the rest, I can have you sit down there for me, please. We'll go to your ankles and your toes. If you want to just kind of can you lift your foot up one at a time and just kind of wiggle your ankle around for me to the left? Wiggle your, let me come down. Thank you for reminding me. Wiggle your ankle around to the left, wiggle your ankle around to the right. Good. Point, flex like you're driving a car, push back, pull in. Great. And squint your toes together and bring them back, fan them out. Great. Okay, and on the other side, the same thing. Kind of wiggle them around to the left, wiggle them around to the right. Good. Push the gas down, bring it back. Squint your toes, and then fan out. Great, and we're gonna pause right there. That's active range of motion. We'll do a pause. So I put him now in a position where he's laying down so that we could I'm gonna do a very limited, I'm not gonna, and as I'm thinking about this, there's no way we can do possibly all of this as passive range of motion. I just don't see we could possibly do all of this. So passive range of motion is you just relax. But if I just wanted to just demonstrate some of this for you, right? What I could do is, for example, his shoulder, right? Could I provide passive range of motion to see what movement he has in his shoulder? I'm just gonna do one side of the body, but I would basically be able to say, can his shoulder, if he was a bedridden patient, go through all of those motions that we just went through with him in a standing position. So I went through some of those motions there. That was shoulder. Elbow, if I had to provide exercises to him, if he was somebody who was bedridden, right? I know that this is again, a ball and socket joint. That is supposed to be a hinge joint. If I wanted to get up here to his wrist, I don't know how well you can see this on video. I'm trying to get you the best view possible, but that I could provide range of motion to him this way and provide to see what kind of limitation or to prevent him from having any kind of functional issues, right? Because I know that these joints are supposed to be loosened up, right? I'll take his hand and open it up and provide to him what they call passive range of motion by working his joints this way. Same thing for the hip would be a little bit harder to do because these are big muscles, but again, the idea that as a nurse, I could come and provide, be able to provide range of motion to him and give him some kind of exercise so that his body would not just completely stiffen up, that we would be giving him some kind of exercise, right? This is kind of me working the knee a little bit, right? And then I can come down lower and I can work the feet and I can work the ankles and all of this stuff like that. But there's a way to do that so that it's actually not bad. And I may be satisfied with that demo. Since I just demoed that, now that I feel good demoing it, that was actually not bad, and that didn't take more than a couple of minutes to demo for you passive range of motion. So I felt good with that actually. So I think that was that shows me that you know how to do it. Okay, so we're gonna continue on. Our next assessment we're gonna continue with the cardiovascular assessment. Again, I have introduced myself to the patient, asked the reason why they're here for the visit. I've done my hand hygiene and assured privacy. And I'm just looking again, we're gonna start with just a general inspection of his skin. Again, I'm gonna put on audio since I'm recording these, that I ask that whoever you're getting for these, that you do like I just did with John. I asked him to take his shirt off because again, for this one, for me, I need to really see landmarks on these so that I know that you know, or if it's a woman, perhaps you can get in a sports bra, because for these, the landmarks for me on both the cardiovascular assessment and the abdominal assessment become key because those landmarks become so critical. So again, and there's no way you're gonna see things like on John when I'm looking at him right now, we're doing things like beyond just looking again for color is normal for ethnicity. There's no discoloration, there's no lesions, there's no issues with vascularity. I could lightly touch him here. His skin is warm, it's dry. There's, again, I personally like to compare my left to my right always. That's just the way I am. That's just how I was trained to make sure that there's no differences in what's happening on one side of the body versus the other. I'm looking at chest wall. The chest wall looks symmetrical on both the left and the right sides. I don't see any kind of bony deformities I'm looking for. I'm looking for the area of hives or lifts, which would generally be in this area here if I'm gonna see them. And I'd be looking at it about at eye level. And if I was gonna see it, it would probably be somewhere through here would be sign of enlargement. I don't see any areas of lift. I would then come on over if I wanted to switch over and go into his nail beds, and I would check his nail beds to see 1001, good. On that side, 1001, on this side, 1001. So capillary refill is about 1 second bilaterally. So that's good. I would now move on to check for my, again, get my stethoscope out. I'm gonna go ahead and check for a carotid bruit. And again, the suggestion was to use the bell of the stethoscope. If I can have you turn toward me, no, your face, just your face.
Okay.
Yeah, and I'm gonna put this here, if you can hold your breath for me. Okay. And no carotid bruit noted in that area. Now I'm going to go ahead and check the cardiac points. And again, it's ape to man, so it'll be your second intercostal space. Aorta. Right across from that, pulmonic. Going down one space to Erb's point. One more space down to your tricuspid. On the left side. Each of these sound a little different. And then another one down for your mitral. Fifth intercostal space. This one I come a little bit over more, a little bit midline. And again, no abnormalities of heart sounds heard in any of the aorta, pulmonic, Erb's point, mitral, or tricuspid, or Erb's point area. While I am also here, let's see what else I need to do before I could check his extremities for edema. I probably could have did that when I was up checking him for, let me put that on camera. This upper extremities there to check for edema of the upper extremities. Go down to the lower extremities. I also want to be checking for edema of lower extremities. as well. I always should be doing those. I should be also checking that down while I'm down here. I should be checking cap refill on the lower extremities, 1001, 1002. It's a little slower on the bottom. His feet are a little cooler to touch down here as well. Just so I'm noting that as well, 1001, 1002. So I've noted circulation in the lower extremities as well as edema in the lower extremities. I can actually palpate his lower extremities are a little cooler to touch as I come down. Okay, so then I need to palpate anterior chest wall for thrills, and for that, it's just a matter of placing your hand here. You'll feel it. The PMI, I usually say, is right around the nipple line. I usually put it right here. You'll usually feel it on the left side if it's there at all. This is the same area. You'll also feel your, hear your point of maximum intensity, or PMI, or your book calls it this apical, identify apical impulse. So I guess I could have did that when I had my other thing there. Listen to it there, and I can also now palpate it. See if I feel anything. Kind of over the left nipple area. For women, sometimes you do have to displace the breasts. And then we say we're gonna be palpating pulses. We're gonna start with his temporal pulses. Again, this is, let me shift a little bit up for you. Temporal pulses. See if I can feel them bilaterally. There they are. Good. Carotid, I do one at a time. You're going to just relax. I don't want to crunch off both carotids at the same time. But again, it's important to compare left to right. Good. And then I come down to my brachial. Brachial, I can usually go across the body. Let me come back this way. Brachial, I can usually go across the body and check at the same time. Good. Same thing with radial. Now, we didn't go over pulses. I didn't show you that, so I'm gonna come down, bring this down. We're gonna do, John, can you pick your feet up so I can get these pulses down on the feet? Let me go up. Let me bring your foot this way. Get it in the camera. Good, okay. Let me see if I go this way. Okay, let me come in this way for your inside of the foot to get your posterior tibialis is on the inside of the foot here. And it's kind of inside here near the ankle. You'll feel it. Oh, there it is. And again, I want to compare left to right. In his case, I'm feeling a little stronger on my right side. Yeah, and then the dorsopedalis should be up top here. There's that one. These are on the top of the foot. And again, I think I feel this one also stronger on the right. They're present on both feet, but stronger on the right. There it is, there. Okay, and again, edema down here while I'm down here as well. There's no edema noted on either extremity and the lower extremities as well, if I didn't say that already. And I think I covered everything on that one. That was pretty good. And we're back on recording. Again, this is Dr. Austin Nation. We're doing our final competency. This one is for our abdominal competency. And so again, I've washed my hands. I've introduced myself to the client. Reason for the visit, hand hygiene, provided some privacy. Again, shirt off or sports bra. Now again, we're looking at the abdomen for this one, right? And we're looking at general skin color. Again, for cleanliness, his skin is clean. There's no striae. There's no ecchymosis, no lesions, no discoloration. His skin is appropriate for his ethnicity. There's definitely no issues with the lesions or anything. I can look and tell that his abdomen, is an abdominal breathing down there. He is not guarding. We're looking at posturing position here, right? He's not flexed, it's relaxed. He's breathing normally from his abdominal area here. Abdomen contour is flat, if I had to describe it. I'm looking now here at the umbilicus area, umbilical area. I don't see any herniations, masses. Like I said, he is an abdominal breather, so I do see some movement. I do not see any pulsations. So I've given you now all of my thoughts about inspection of the abdomen, just looking strictly at his abdomen. Again, I remind you that our quadrants, oh, you're jumping. That's the, he's ticklish. Let's be prepared. The division line is at the umbilicus and this way and that way. So now we're going to go ahead and do our auscultation, and I'm going to be listening for, I'm going to go ahead and do my bowel sounds first. And I am always on the right side of the patient, just so I emphasize that. So why? Because I do everything from right lower around clockwise, so that whatever pattern you're using for your assessment, that there's a pattern to it. That's the other piece I didn't suggest. So if you're gonna start up here in the left, in the right upper quadrant, then you do your circular, whatever, and end up back up here, right? So as you're putting your routine together, pick your place to start. I tend to like to start down here in the right and just work in a sort of a clockwise manner. It just works better for me. So, and again, your book technically says 5 minutes in each quadrant. We don't have that kind of time. He's a little jumpy. So once I hear bowel sounds, are the bowel sounds hyperactive? Or I think your book uses normal active or hypoactive. You have choices of words. I mean, I'm okay with bowel sounds active. That tells me that at least stuff's moving through. Yes? Yep. So I just go until I hear some gurgle, and I'm a happy person, because I know then stuff's moving through that flow that we talked about earlier, and it's going through the system here. So then we talked about auscultating for vascular sounds, and this is where I'm gonna go ahead and use my little book here as a reference guide. So it's set to go above my quadrant. I have my note here that I wrote midline above my quadrants. So if my quadrant's there, I'm gonna go up above my area here. I can see almost on him where it would be up here in this area is where I would expect to hear my abdominal aorta sound, if there was one. If he had issues, if I was going to hear any kind of bruit, if he had issues with hypertension, I would expect to hear it somewhere, because we know the aorta runs right down the middle here, right? And then off to the side, left and right, we would get our renos. And again, I want to stay up high, stay above that quadrant. So same thing, left and right. These are the renal arteries I'm listening to. Iliac arteries are down here by the umbilicus. So there'll be a different sound other than bowel signs, left and right. And again, we're gonna omit the femoral arteries. Okay, so I said we palpate last. So I'm gonna go here and we're gonna do tympany over the different quadrants. You want to put your hands down for me here on the side so I can just, so again, good, nice and dull, good, good. And there's dullness heard in all 4 quadrants, which is nice, which is the sound that I'd like to hear in all 4 quadrants. There's nothing sort of a tympanic sort of dullness going on in all 4 of his, on all 4 quadrants of the abdomen. Now this other new test I'm gonna try this is this MCL liver span test. Now I'm gonna try this one here to see if I can do it. So it says start below the umbilicus and listen, see if I can work my way up from tympanic to dullness. Or I'm going to be working my way up here, and then I'm going to be working my way down here. And again, there's a picture of this on page 497. I give you a picture of this one as well. This is a new test for me. And I'm going to be seeing if I can hear, he's so jumpy. There, say. Ooh, right there. Okay, so if I had a pen, I'd mark like a spot here. That's where I'm hearing it, a change. It's really dull. Wow, really dull there. I can tell the difference.
This is my red, I think.
Huh?
I think my red.
I think it's your liver. Relax. So it should be right below. That's about where your, that should be about where your liver is. So I'm marking it. If I had a pen, I put a little mark right there, right? And then it says start at his nipple line and work my way down. So I know this is my MCL liver span, right? Which is about where I would expect to feel his liver. Let's see. That's tympanic. Sounds the same. Sounds the same. Sounds the same. Okay. All right, that test, I'm gonna do something. Let me go back over here. Oh, that was a little shift. Very subtle difference. So somewhere right in through here would be what I would anticipate to be as my area for my MCL liver. I'd give it to you about here in this area. And I would mark that and I would talk about that as my area of the liver span, which would be about right. All right, and then we're gonna move to our light and deep palpation. And again, I start in the same area because I do everything from the same area. So again, this part of my hand, I'm not digging in with my fingers because he's already jumpy. And I would just start with a very light palpation. And when I'm doing palpation, the other thing to say is I'm gonna shift the camera a little bit so you can see his face. Because you always need to be watching your patient's face when you're doing palpation, because I'm looking to see if I'm bringing any kind of discomfort to him while I'm kind of massaging around in these areas, right? I don't want to hurt my patient, or if I'm noticing he has any discomfort as I'm moving to these different quadrants, because I know now what's in these quadrants that I'm massaging. I want to be able to take note of what quadrant he's grimacing in or any of that while I've gone around to his quadrants. So, and I come back to my home base. So I've gone and I've done palpation in all 4 quadrants. There's been no tenderness noted. I felt no masses, no nodules. Patient has had no tenderness, no grimacing, right? Now for a deeper palpation, and again, I start at my home base. I'm gonna ask him to take a big breath in and out, and take a big breath in and out for me. And he's go out, I go a little bit deeper in with my massage or my palpation to see if I feel anything a little deeper in. No. Okay, good. He's not grimacing. Again, watching my patient. Good. And we know what's up in this area. Good. No. Good. Okay. Two more. And I feel all his livers. He's got no fat on him. So jealous. In and out one more time. And there. Again, no grimacing. Great. Okay, so no masses or tenderness noted to deep palpation in all 4 of the quadrants as well. And then the last part of this is the McBurney's rebound. Right? So we know the McBurney's point is somewhere between, is that showing on your camera? Yeah, between here and here. I'll just show it with 2 hands. You talk about the McBurney's point being in here because we know it's in the right lower quadrant. So what I do is I go from this side of the patient, where I come in on this side, pull and let go. Rebound. Usually 1 hand because I'm a big guy. Bring it in toward me, let go, rebound. And I watch to see if they're a real acute appendicitis, they're gonna fly off this sofa, if that's a true appendicitis, right? And so rebound, no rebound tenderness, noted with no rebound tenderness noted, period. And that covers all of that. So it's not bad.